Hi, I'm Sonu Jain, and I'd like to welcome you to our second of our AHS Advanced Practice Provider webinar series, Snakes in the Grass, Avoiding Misdiagnosis of Common and Rare Hand Conditions for APPs. So what you will gain from this webinar, thanks to the generous support of Endo Pharmaceuticals, is free access to the webinar series, 1-year complimentary AHS affiliate membership benefits, discounted annual meeting, free partner guest child registration, and much other things. And stay tuned for upcoming webinars as well. One more coming up. If you can go to the next slide, please. So we did have, oh, sorry, if you can go back one slide. Oh, okay. So yes, so we did have a previous webinar series that you can access through our website at handsurgery.org. And we do have an upcoming webinar next month that will go over the application and how to properly administer Xiaflex for deep regions contracture. Next slide, please. And I'd like to introduce our moderator, Dr. Glenn Gaston from OrthoCarolina. Glenn?
Yeah, thanks, Sonu. So one of the big things I want to shout out again to Endo Pharmaceuticals for supporting this lecture series. It's a great opportunity for not only great learning today, but as was mentioned, a free membership moving forward. And tonight is an exceptional group of panels. So we've got Marc Richard joining us from Duke. We've got Jen Waljee. We've got Carrie, Bettlach. It's a phenomenal crew. They've put together 3 outstanding talks about things that you're going to just see in your practice and things that are going to see you, and you pray that you see them at the same time. So next slide. And then the other thing coming up, we've got the annual meeting. You can progress to the final slide. The annual meeting's coming up. For those of you that haven't registered, now that you've attended this webinar, you'll be able to go to the annual meeting at the member discount as opposed to non-member discount. It's in Hawaii, so if you're looking for a great chance just to go to Hawaii, it's a write-off trip, and it is a great venue and great educational opportunity. So please join us if you haven't already done so. And with that, we're going to unshare this, and we're going to turn the share screen over to Carrie, who's going to get us started.
All right, can everybody hear me okay?
Perfect.
Yes. Great. Thanks for being here tonight. My name is Carrie Bettlach. I'm a nurse practitioner currently practicing at Washington University in St. Louis. And I'm going to talk about some bony injuries that you may see present to your hand clinic. We're going to talk about identifying these diagnoses, recognizing which condition should prompt surgeon referral, and then discuss management strategies. My presentation is obviously not all-encompassing, but I hope to hit some highlights of both common and some less common presentations that you may see. So we're going to jump right into some cases. Case number 1 is a 16-year-old male who presented to the emergency department. 3 days of right thumb pain after he injured his thumb playing football. There was some pain and swelling of the right thumb with intact motor function. X-ray findings showed some ossified densities with some cortical irregularities. This was read as unlikely to represent fractures, and a hand consult was not placed. He was splinted, and he was referred to my clinic for follow-up, where I saw him. He described that he hyperextended his thumb during injury playing football. He actually felt a pop. On my exam, he had a moderate amount of edema. He was tender along the ulnar aspect of the joint. There was no palpable mass, but he was extremely lax with gentle deviation at the MCP joint. So immediately my brain went to thinking about the anatomy at the MCP joint. And collectively, that dorsal capsule and volar plate, along with those collateral ligaments, are going to act as the static stabilizer of this joint. The ulnar collateral ligament specifically is going to provide some resistance to that valgus stress, and it's going to prevent volar subluxation, contributing to pinch strength. So I examined his MCP joint with a bit of gentle stress at the joint. He was very lax, and I went ahead and got an MRI. And you can see in this image here, the MRI actually did show a Stenner lesion. So there was a complete tear of that UCL, and that adductor pollicis aponeurosis is actually trapped between the torn UCL and the proximal phalanx of the thumb. You can see the normal radiocollateral ligament at the top of your screen with the blue arrow, and then kind of that mass depicted by the red arrow. So he was taken to the operating room. You can see suture anchors in place here, which show the thumb in good position. He was casted for 7 weeks, splinted for 4, ultimately went back to playing football, which was his ultimate goal. So some tips and tricks when looking at this type of injury. So pain in guarding or intolerance to manipulation at the joint can cause a false negative result. That contralateral side is key when you're assessing baseline stability or laxity, and then imaging or further imaging can be helpful. All right, case number 2. This is a 13-year-old female that presented to the emergency department. She injured the left ring finger when wrestling with her younger brother. There was an obvious deformity of the nail plate that had flipped up from under the hypomagine. Her PA showed widening of the physis. This is further demonstrated on the lateral, and you can really see this displacement. So when we're looking for these types of injuries, we're thinking Seymour fracture. That displaced distal phalangeal fracture involves the physis, usually with an associated nail bed injury. And it's actually that interposed germinal matrix is entrapped at that fracture site. In order to reduce the fracture, you have to extract that. And there's significant consequences associated with missing this. We typically take these to the operating room at my institution. The entrapped nail elements are extracted, fracture washed out, and pinned. And you can see the position of post-op with that pin holding everything in place. So when evaluating these pediatric fingertip traumas, most of them are not going to be Seymour fractures. They're going to look much more like the image to the right of the screen with a distal tuft fracture and a nail bed laceration. These are much more common, but you do have to rule out a Seymour fracture. That DIP joint is often going to present in a flex position, and then that lateral x-ray is really going to be key in confirming this diagnosis. Case number 3, this is going to be a lot more common. So this is an 11-year-old boy that fell off of an electric bike. He again was seen in the ER, and his fracture was deemed non-operative. He was splinted and referred to my clinic for management of this right small finger metacarpal base fracture. I unfortunately don't have films. I took him under fluoro and the office, and I guess I didn't save them, but of what he looked like originally on that first follow-up. But he had loss of height, and then more importantly, on my exam, he was malrotated. So I did go ahead and refer him back to my hand attending on call. The images to the top left are going to show intraop, and then bottom right are going to be about 1 month post-op, just prior to those pins being removed. But you can see he has improved height, and more importantly, his cascade is back in normal alignment. At 6 weeks post-op, he had full range of motion, no scissoring or malrotation noted on the exam. So I think the key with this is really trusting your exam. So sometimes you'll get things, or at least I get things sent to me, and it's a plan for a non-operative fracture. The x-ray read will say, minimally or mildly displaced. Don't let those types of words trick you. Trust your exam. If the patient is scissoring or malrotated with these types of fractures, that's going to indicate surgical referral. Those digits should align towards the scaphoid tubercle with active flexion. And then sometimes it's hard. If patients are really stiff and they're not wanting to move, sometimes you have to rely on other maneuvers such as, tenodesis of the wrist to try to really evaluate their cascade and how those digits are aligned. All right, so case number 4, this is a 16-year-old. He presented with this bony mallet of his left ring finger, which he sustained while playing volleyball. Looking at the lateral, especially, you can really appreciate this bony mallet. He was splinted in an aluminum extension splint, referred to clinic for follow-up. So with those mallet fingers, we know that terminal insertion of the extensor tendon is disrupted. So they're not going to be able to extend at that DIP joint, and that joint's going to present with this flex position. These can be bony or non-bony, and most of the time these do just fine with non-operative management. So 6 to 8 weeks of full-time DIP extension splinting, usually that does the trick. However, if that fracture fragment is large enough, greater than 1/3 of that articular joint surface, or if there's subluxation of that distal phalanx, those are going to indicate the need for surgical intervention. In this case, we just took this to the operating room last week. You can see that bony mallet there and the involvement of the articular surface, maybe about 40%. So he went to the OR for extension, a dorsal block, which was placed first, and then this extension pin down the pike to hold that dividend extension. And otherwise, we'll proceed with normal mallet protocols, treat him with the pins in for about 6 weeks as well, with a splint to also support that joint in extension. So most of these, again, can be managed non-operatively, looking at that subluxation of the distal phalanx or the percentage of that fracture and its involvement with articular surface is what you're going to want to look at when you're thinking about referring these for operative intervention. Case number 5 was interesting. This isn't necessarily something that I think is probably going to present very often, but I do think it's worth mentioning. This is a 20-year-old that was involved in a motor vehicle collision. This was polytrauma, lots of injuries. About 1 week after the motor vehicle collision, he had presented to clinic with complaints of, his main complaint was numbness throughout his left hand. On 10-10 testing, he had about 6 out of 10 sensation throughout the median nerve distribution, and he had Tenels at the carpal tunnel. X-rays, numerous X-rays during his inpatient stay and outpatient initial follow-up were read as negative. He had moderate edema of the left hand and forearm, but he did have bony tenderness, dorsal wrist, and as well as the ulnar style. So his initial X-rays, if you look closely at this PA where that red circle is kind of at the base of the 3rd and the 4th metacarpals, there's a bit of discontinuity at the CMC joints. And then looking at this lateral, you can see that that lunates in its expected position. Scaphoid's tipped anteriorly, but there's something going on at the base of the thumb that's just not really clear. So we got a CT scan. And the CT scan went ahead and showed that this, the capitate is really completely tipped forward, completely displaced from its relationship with the 3rd metacarpal. So it's anteriorly translated into the carpal tunnel. He was taken to the operating room. And upon opening up the carpal tunnel, you can see that that capitate is just sitting within those carpal tunnel contents. So this was most certainly contributing to the numbness that this patient was experiencing. He went ahead and had the fracture reducing pinned. Again, I don't necessarily think that the operative course is the most important, but I think that when you're looking at something like this, it's questioning when those symptoms and injuries don't align. So negative X-ray had tons of numbness. What's going on? Don't rely necessarily on that negative X-ray alone. And then you can also pursue additional imaging to help you kind of get to that diagnosis. Last case I'm going to talk about is a 15-year-old that jammed his index finger while playing baseball. He was seen in an outside hospital. He underwent reduction. You can clearly see this P2 base fracture. It's characterized by impaction and then this dorsal V sign, which is outlined in red. A CT scan was obtained to get a little bit more information, further characterizes this fracture subluxation at the PIP joint. And I bring this up because early recognition of this type of fracture is going to allow for much less invasive procedure and quicker motion for the patient. So this was identified early. He was taken to the operating room for reduction and placement of this external fixator. And this allowed us to refer him to therapy and get him moving early, saving him a much more invasive procedure with a longer rehabilitation time if this were missed or not caught initially. Post-op, he did really well, was back to playing sports. You can see he healed nicely. So recognition of these impacted P2 base fractures allow for early intervention. This can minimize that risk for more invasive procedures down the road. That dorsal V sign is going to be really key in identifying these types of fractures, pretty characteristic. And then moving the joint with early active motion is going to result in less long-term stiffness. My references, and that's all I have. Thank you.
Thanks, Carrie. That was awesome. I love that case 5, that CMC dislocation. That's a really cool one. And I love your point is so good. Like it highlights the whole, if it just doesn't add up, get more information. That's such a great pearl. And I should have mentioned earlier, for all the people on the call, please put any questions you have along the way in the chat. And then at the end, we'll spend some time, because the speakers are going to save some allotted time for us to go through your questions. So please add those to the chat and we'll address those. And next, Marc's going to take us on.
All right. Thank you, guys. Carrie, that was awesome. I am going to shift gears a little bit and talk specifically about sneaky nerve conditions and how they can get confused with other diagnoses. So just as an overview, we're going to talk first about some of the scariest ones, when compressive neuropathy can be confused for motor neuron disease. Then we'll take each of the major nerves of the upper extremity: median nerve, radial nerve, ulnar nerve, look at locations of compressions and little subtleties about when something is different, and then where there's a little bit of overlap with other pathologies and some of the specifics, and we'll work through that together. So let's just get the scary ones out of the way. You know, carpal tunnel is very common, and despite classic exam findings, presentations vary, and I think we all see that. And we're accepting of these varied presentations. And it can be very easy to get into that hammer nail syndrome where everything seems like carpal tunnel. Two of the things that we have to worry about are ALS and MS. So ALS, or amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, is a neurodegenerative disorder affecting the upper and lower motor neurons. Typically starts distally in the hands and feet and then results in muscle weakness, cramping, and fine motor difficulties, similar to carpal tunnel before it moves to the proximal muscles. The thing about ALS is that in the end, there'll be multiple muscle groups that are affected, not just median nerve. You don't know where you are in its presentation. Early on, it can just be the hands and can feel like carpal tunnel. I think for this one, EMG is really important. You'll get different findings of the EMG. For ALS, you'll see reduced recruitment and large motor units on EMG, which are not present on carpal tunnel. And then ALS will almost always have normal sensory nerve conduction velocities. It's the motors that are off. And that is very uncommon of carpal tunnel. Carpal tunnel starts with sensory. Fibrillations and positive sharp waves can be present in both, but fasciculations are only present in ALS, specifically tongue fasciculations. So the thing you want to do is ask the patient to stick their tongue out. And you'll see, I wish this was a video. It's jumping all over the place. It's fasciculating, and it is not normal when you see it. And it is not carpal tunnel. The other one is MS, which is an autoimmune disease that damages the myelin sheath of nerves in the CNS. So it can be in the spine or in the brain, can affect the sensory and motor function in the hand, similar to CTS. EMG can be normal in MS in the early stages, but MRI is really, demonstrative of it. It can show plaques in the brain or spinal cord, and then you get more systemic symptoms in later disease. So keep those two diagnoses in mind when you're seeing carpal tunnel. As we move through the median nerve doesn't just end up in the hand. It gets through the proximal portions of the upper extremity and has this very specific anatomic course that I know we all know. Each one of these nerves passes the elbow between the heads of two muscles. For the median nerve, it's between the two heads of the pronator teres, and that is a site that it can get entrapped. So anywhere along the course, you can get median nerve entrapment, and it can feel like carpal tunnel to the patient with a few little exceptions. And two of them that we'll talk about are pronator syndrome and AIN syndrome. Places that the nerve can get caught up can be the ligament of Struthers, and we'll talk about that, and the supracondylar process of the humerus, Lacertus fibrosis, the deep head of pronator teres, or the FDS arcade. And the pronator pronator syndrome is the source of compression of the median nerve. It's classically described as compression between those two heads of the muscle, and it can be caught anywhere along the path. It's usually an insidious onset of volar forearm pain. Patients will have very similar complaints to carpal tunnel. Dynamic symptoms can be related to repetitive pronosupination as the pronator teres works, and that's a distinction from carpal tunnel. But the real thing on history and clinical exam is that you won't have your typical findings of Tinel's, Durkin's, and Phelan's at the carpal tunnel. You might have a Tinel's over the forearm. You're not going to get those nocturnal symptoms of the changes in the carpal tunnel positionally, because that's not where the nerve entrapment is. And a careful exam, and this is probably the big thing, demonstrates decreased sensation in the palmar triangle. So in that blue area there, that palmar cutaneous branch, remember, comes off proximal to the carpal tunnel. So if that is altered in sensation, as compared to the contralateral side. It is not carpal tunnel. It is a compression a little bit higher up. Clinical exam, again, provocation, I should say, with resistance against pronation and pain or Tenell's proximally can be a sign that pronator teres can be the potential site. You do also have to think about supracondylar process and the ligament of Struthers, the median nerve off the and the distal under the humerus will pass underneath that and get compressed. It's only about 1% of people who have this in the human population, but cats have it. So I always get an X-ray if I have a weird presentation, and then at the very least, I can reassure the patient that they are not a cat. Ultrasound or MRI if you have a mass suspected somewhere in the forearm, but otherwise, clinical exam is going to be the mainstay. I know we're not really going through treatments, but I put the treatments in here just to say that when you run across these, almost overwhelmingly, these are going to be non-operative first. You can get medial epicondylitis associated with pronator syndrome. So if you have that, treat the epicondylitis, and a lot of times the pronator syndrome gets better. If you do have to release it, it's an S-shaped incision in the proximal forearm. It's going to be more proximal if you have a ligament of Struthers as a potential site, but you release the constriction along the entirety of the median nerve, specifically at the two heads of the pronator teres and the FDS, the fibrous arch of the FDS. If you look at outcomes for this, they really don't do well. They're not as good as carpal tunnel, so you'd much rather see carpal tunnel than this, but it does give you the ability to counsel your patients with what they have and what the results may be. AIN syndrome is a little bit different. Typically spontaneous loss of the ability to flex IP joint of the thumb and DIP of the index finger, but it's a purely motor problem. There's normal sensation to median nerve. Typically, this is going to be a parsonage Turner where they have a post-infectious neuritis. And if you ask patients on history, they'll often come up with a recent viral infection or a cough or just kind of junkiness in their chest that they felt a few days to a week even before they started to have this. I think the big things to think about with this when you're seeing this is you may think it is some kind of tendon injury and a tendon rupture like you might see in rheumatoid arthritis, like a Mannerfelt lesion with an FBL rupture. You usually do not need higher order imaging. Don't forget about the value of tenodesis. Simple tenodesis of the wrist will show that the tendon is intact and that it's a motor problem, not a tendon problem, and it'll spare you from getting the expensive MRI when it's not necessary. So check that tenodesis effect to rule out tendon injury. Electrodiagnostic studies are confirmatory, but they're not requisite. If you do think there's some kind of mass compression, then you could get imaging studies, but otherwise typically not needed. Again, treatment is conservative. OT for splinting and maintaining the thumb in good position for pinch while this all resolves, and it typically resolves without surgery. I've never actually had to operate on an AIN. Let's move into radial nerve. Radial nerve splits into two branches, the deep and superficial, specifically PIN and SPRN, a few centimeters proximal to the leading edge of supinator. I do think that radial tunnel syndrome, I do think that it is rare. It is real, but rare. It's a pain syndrome, and it doesn't make a lot of sense, but I do believe I've seen it. I do believe I've seen it get better. There's no motor weakness with it. It is simply pain, and it is a few centimeters distal to where you see lateral epicondylitis. There you can see the course of the radial nerve going between the two heads of the supinator. Like we discussed, the radial nerve crosses the elbow between the heads of two heads of a muscle, in this case, the supinator. It does have a very defined anatomic area that needs to be released if you are going after it surgically, but the arcade of Frosch, which is the tendinous edge of the leading edge of the supinator, is what's thought to be compressive, and that tendinous edge is present about 87% of the time. So whether you believe in it or not, I think it's worth looking for, making sure it's not identifiable things that everybody believes in, like lateral epicondylitis. It's a solely clinical diagnosis of exclusion. There's no pathognomonic signs. Palpation 4 to 6 centimeters distal to the lateral epicondyle is one of the hallmarks that you do see. You want to make sure there's not another identifiable source. And the two provocative things you can do are resisted long finger extension, which in my experience is also present in lateral epicondylitis, and resisted supination, which can tighten the leading edge of the supinator tendon against the nerve and give you pain in that area. Treatment is going to be rest, corticosteroid injections, anti-inflammatories, activity modification. If you ever do release it, you have to do a complete surgical release of the PIN, and that involves releasing the arcata frosh, and the outcomes are a little bit all over the place. So again, try to stay away from it if you can. PIN, posterior interosseous nerve syndrome, is different. It's radial nerve palsy. It's a motor loss with no pain, but the same exact anatomy as radial tunnel syndrome. There's, again, no sensory changes in this one, just motor. But there's a few things in your differential that I think you really have to think of. One is going to be a mass proximally in the forearm, like a lipoma or a ganglion. I've seen both of those. If it's a rheumatoid patient, you can get synovitis at the radiocapitellar joint. That can put pressure on the nerve. And also in the rheumatoid population, if they cannot bring up their MCP joints, you have to think about von Jackson syndrome, which is a rupture of the extensor tendons as it passes over the DRUJ, or simply MCP dislocations like you see here, which is also common in advanced rheumatoid that's refractory to medicine. Tenodesis is your friend in this. Again, check the tenodesis and you'll get a sense of whether or not those tendons are intact and if this is a muscle or motor problem. If you do suspect a mass by physical exam, MRI is appropriate, and electrodiagnostic studies are positive and can be helpful in quantifying the severity of things. Treatment is exactly as we talked about previously. You're going to start with non-op, including rest and immobilization. But if you do have to release it, usually more than 3 weeks, you're going to release the entirety of the PIN. Here you can see that kind of hourglass deformity at the leading edge of the arcata frosh in the supinator where the PIN enters. And with that, you get good release. And these actually do well on the motor side if you find that. I'd rather see this than I'd see radial tunnel syndrome. Let's finish with cubital tunnel, which is the second most common entrapment. But what are you worried about confusing cubital tunnel syndrome with? We know the usual sites that we release at the medial side of the elbow. One of the things that you see in cubital tunnel is that dorsal cutaneous branch of the ulnar nerve, or the dorsal ulnar aspect of the hand and wrist, is involved because that branch comes off above the wrist, distal to the cubital tunnel. So if that is involved, you're looking at a high source, most likely cubital tunnel, but not always. You do have to worry about thoracic outlet syndrome, which on the neurogenic side will affect the lower portion of the brachial plexus. You have to worry about Pancoast tumor if you have a smoker who can have that tumor in the apice of the lung, pushing on the underside of the plexus, which would be confusing with the ulnar nerve. On the distal side, if you have ulnar tunnel syndrome, you can get many of the other changes that you see with cubital tunnel, but you will not have disruption of the dorsal cutaneous branch of the ulnar nerve, again, because that branch comes off above the ulnar tunnel. So use that dorsal cutaneous branch of the ulnar nerve as a big clinical exam finding. Lastly, snapping at the medial side of the elbow can be two things. It can be a subluxating nerve, which Carrie's group at WashU has shown is present in 37% of the normal population. But you can also get another pop, which is the medial head of the triceps. And really important to look for two different distinct pops. If you have two snaps on the medial side and they're at different degrees of flexion, you likely have not just the subluxating ulnar nerve, but the medial head of the triceps dislocating as well. And they typically occur respectively at 70 to 90 degrees for the ulnar nerve, and then 150 to 15 degrees or more advanced flexion for the medial head of the triceps. Imaging, dynamic ultrasound is probably the best tool that we have. As far as management for medial snapping triceps, you can either resect it or lateralize it. I've learned that these are big, bulky guys that do a lot of weightlifting. They do not like being told you resected some of their triceps. So I would talk to them about lateralizing it. You're just centralizing it and sewing it into the central tendon so they didn't lose any muscle mass. And we'll finish with just a couple of videos. This is a subluxating ulnar nerve. You can see it popping clinically. Once we get in there and expose the nerve, you can see it jumping over the medial epicondyle. Again, this happens in a lower degree of flexion, just south of 90 degrees, where you'll see that start to pop over. and this is after transposition. And you see here, in this case, the medial triceps is not jumping over the medial epicondyle. Let's look at this one, which in this case, you can see, this is Dave Rush's case, you can see medial head of triceps popping over. There's a snap right there. And then after translocation of it, so that you did not resect it, you can see you've got no triceps snapping over the medial epicondyle here. So you've cured both of those problems for the patient. So take-home points: knowledge of uncommon causes of compressive neuropathy can minimize complications, know the difference in the exam findings, know and rule out all the differential diagnoses, and know that for nerves, at the very least, non-operative management remains the mainstay of treatment. Thank you.
Thanks, Marc. That was outstanding as always. And now Jen's going to bring us home with the final talk. And again, add all your questions to the chat, because after Jen's talk, we will address all the questions that come through the chat. Thanks.
Thank you. What great talks. It's a hard act to follow. So I'm going to try to round us out today with skin and soft tissue, snakes in the grass. I'll have some common things, some not so common things that aren't necessarily dangerous, but important to know, and then some things that we definitely don't want to miss. So with that, most of what I'm going to talk about tonight either falls in one of these three buckets: cancer-related conditions, inflammatory arthropathies, and infections. And I think three of the themes that you'll hear as I go through these slides are: have a low threshold for biopsying lesions, or things that you're just not sure what's going on; have a low threshold for culturing things; and have a low threshold. I mean, we always want to be mindful about not overusing diagnostic imaging when it's not appropriate. But I think for many of the things that we'll talk about, there are some kind of key things that have in the back of your mind that may trigger, like, hey, maybe I should get an ultrasound here, an MRI or a CT, and we'll talk about those. So I kind of categorize this for things that patients might come in and complain of. One thing here is, patients may come in and say, hey, my nail looks funny. What's going on with this? So common things being common, most often this is related to some type of nail trauma. Most of the time, a patient will remember what this is, but not necessarily always. And they may represent an acute or a more chronic subungual hematoma. Fungal infections are also common. Melanonychia, which is benign, is common. And it may be some less common things, but also impacting how the nail plate grows out. So psoriasis, medication changes, metabolic disorders, pyogenic granulomas from remote trauma under the nail bed can also occur. But of course, what we're worried about here are subungual melanomas. And so what kinds of things do we need to be thinking about that in terms of the diagnosis? So melanonychia versus melanoma can be a little bit tricky to discern. And so again, I think this is one of those situations where having a low threshold for biopsying and engaging our colleagues in dermatology is really important. So there's the ABCDEF criteria that are outlined, and I put the references in the slide. Also happy to share them offline if anyone is interested. So age, the incidence of subungual melanoma is higher among older individuals and higher in certain populations. Bandwidth, so you can see in this particular picture here, it's a relatively wide bandwidth compared to the more diffuse bandwidth that you see in the upper corner of that particular picture. And if it's got a more distinct black or brown lesion color, certainly anything that's changed. Subungual melanoma is more common amongst the thumb and index finger lesions. If it's extended to the surrounding skin, that's called Hutchinson sign. And if there's any personal or family history of skin cancers. With these, I think it's really important to biopsy them. Sometimes they'll come referred to us from our colleagues in dermatology, but if this is a lesion that is not necessarily associated with trauma, it hasn't grown out over a period of time, I do think it's important to consider biopsying these. I personally think that the best way to do that is to remove the nail plate, and so that requires some additional counseling for the patient of what to expect around that. But I do think that that gives you the best chance to get both the germinal matrix and the sterile matrix, and get a good solid biopsy so that you know that this is benign, or if there's going to be additional things that you need to do. So indications for that: isolated melanonychia, especially of the thumb and the index finger, a changing appearance with proximal width greater than distal width, lesions that haven't responded to treatment when you would have expected that this should have initially grown out or responded to like an infectious treatment or from like a fungal infection. Bandwidth that's greater than 3 millimeters, definitely if it's greater than 6 millimeters, irregular indistinct borders, a Hutchinson sign, again, family or personal history, and certainly anything that is bleeding or has an ulcerated component to it. Oftentimes we'll see patients that come in that may have changing skin lesions. Sometimes this is related to what we're seeing them in clinic for. Sometimes it might just be something that they mention in passing. Often these are really common things like benign nevi, bites, rashes, again, medication changes. But we want to make sure that we don't miss a skin cancer. And so the most common ones, especially on the dorsal aspect of the hand, are squamous cell carcinomas and basal cell carcinomas because they're related to sun exposure. Again, melanoma, Merkel cell carcinoma, and the sarcoma variants and sweat gland tumors are much less common. But again, anything that seems like it's unusual or ulcerated on the hand, you're going to want to think about getting a full thickness biopsy of. Again, just another comment on melanoma that's not necessarily a subungual melanoma. These are relatively uncommon when it comes to cutaneous malignancies, only about 4%, but they do account for 80% of deaths due to distant metastases. For the most part, the treatment of this is wide excision and closure with or without sentinel lymph node biopsies. For these, I often will consult my colleagues in dermatology, or they're going to be, their case will be reviewed at a tumor board. So it's important to get your colleagues' input, especially if you need to work them up for distal metastases. For subungual hematomas, there are melanomas. There are newer literature regarding digit-sparing therapies, but for the most part, many of these patients are going to go on to require amputation. There are Mohs options with our colleagues in cutaneous oncology. So again, involving them in their care early on is important. And then it's also important to note that any of these patients that you end up seeing that have melanoma or any other skin cancer, they're going to require routine surveillance. So making sure that they're plugged in with dermatology with routine skin checks is important. Squamous cell carcinoma is the most common skin cancer, commonly found on the dorsal aspect of the hand. It can prevent in a whole variety of ways. Most commonly is the picture that's shown above. This is an elderly patient who had kind of a non-healing wound. The picture in the middle is a patient of mine who had graft versus host disease, and so presented with this fungating lesion over the dorsal aspect of his forearm. And again, these also can present under the nail plate as well. Actinic keratoses are precursor lesions for this. Unfortunately, most of these are not aggressive and they rarely metastasize. Keratoincanthiomas are a derivative of these, which are rapidly progressive but again, rarely metastasize. So again, coming back to anything that's a changing lesion, you're going to want to get a biopsy of. It's also important to note that this is more common among our patients that have had solid organ transplants. And these individuals will tend to have local recurrence. The rates are somewhere around 13 to 15% within 6 months. And they also have a higher rate of distant metastases. For the most part, the treatment for these lesions is excision with 4 to 6 millimeters. For more aggressive lesions, we will often involve our colleagues in radiation oncology to consider radiation therapy, particularly if you can't clear the margins. And again, routine surveillance is important for these patients. Basal cell carcinoma, it's less common than squamous cell carcinoma, again, associated with UV light exposure, so common amongst the hand. And again, often will present with a non-healing wound, a crusting area, or a shiny nodule. So have a low threshold to biopsy, either a punch biopsy or an excisional biopsy of those lesions. And for the most part, the treatment of this is wide local excision. Merkel cell tumors are very uncommon. They're of a neuroendocrine derivative. They do have a propensity for rapid growth and metastases with a low 5-year survival rate of approximately 60%. So they're a fairly aggressive tumor. They often, again, will present with a relatively non-specific lesion, and I'll show you a picture of that on the next one, the next slide here. This is a case here from my colleague, Dr. Haas, and you can see this kind of scaling, crusted lesion over the dorsal aspect of the small finger. This does require workup for nodal disease and distant metastases. So you're going to want to involve your colleagues with, in surgical oncology. And there's no clear survival difference with local excision versus Mohs. You can see in this particular case, the patient required an amputation. And this is another case of a Merkel cell carcinoma. This particular patient came in with a very nondescript posterior elbow lesion that rapidly progressed over about 3 to 4 months to the lesion that you see there on the far right, ultimately requiring nodal sampling and wide excision. I'll just make a few comments here on sarcoma. So sarcoma, again, is quite uncommon in the upper extremity, but I do think it's something to have in the back of our minds, particularly as we see lots of patients with lots of different lesions. For the vast majority of them, these are benign lesions, oftentimes lipoma. But I do think it's important, particularly for larger lesions like this one, to think about getting additional imaging. You can also engage our colleagues in radiology to get core needle biopsies. The most common sarcomas of the upper extremity are DFSP, epithelioid sarcoma, synovial sarcoma, and liposarcoma. And you can see here that the survival rates drop down at about 5 years. So important to catch these. Also important to have imaging around these ahead of time, so it helps you plan your resection, engage your colleagues as needed. Okay, so I'll move now into kind of the inflammatory or rheumatologic conditions that can present as things that are really common, but also require us to engage our colleagues in other specialties to make sure that we're caring for all the sequelae of these conditions. So lots of times patients come in to see us and they say, I had this mass on the back of my wrist here. For the most part, these are ganglion cysts or some type of tenosynovitis for any number of conditions. They can be benign proliferative tenosynovitis from overuse, could be a carpal boss, it could be an effusion from post-traumatic wrist arthritis. But I think the things that we don't want to miss here is, does this represent rheumatoid arthritis or another more systemic cause? So rheumatoid arthritis can certainly present with local joint swelling. What is different about this from benign tenosynovitis, especially if you sample it, is that this will show papillary hyperplasia, fibrinous adhesions, marked inflammation, and lymphoid nodules, and most importantly, infiltration of the disease into the substance of the tendon. And this is what can result in tendon attrition and rupture. As you can see here in this particular case, this is a patient of mine who came in with focal tenosynovitis over the dorsal-radial aspect of his wrist, resulting in an EPL rupture. The diagnostic workup of patients with rheumatoid arthritis is nuanced and in some areas controversial. So I think this is an opportunity for us to engage our colleagues in rheumatology. Radiographs may often be negative in early disease. The classic symptoms and signs of this that should prompt workup are pain, swelling, and stiffness in 2 or more large joints for over 6 weeks. Oftentimes, patients will complain of swelling and stiffness in the morning, fever, fatigue, and unexplained weight loss. We will often go ahead and refer these patients for laboratory values, including sending off for a rheumatoid factor, anti-CCP, sed rate, and CRP. There is a greater risk of rheumatoid arthritis among women, among individuals who are smoking, individuals with obesity, and individuals with a family history. And other things to be thinking about in the differential diagnosis, and we'll talk about a couple of these: psoriatic arthritis, infectious polyarthritis, gout, CPPD, and lupus. So it's important not just to consider the upper extremity manifestations of rheumatoid arthritis, but the real reason to make sure that they're plugged in well with our colleagues in rheumatology is that we're screening and mindful of all the other sequelae of RA, including myocarditis. They have an increased risk of MI and strokes, pulmonary complications, including effusion, interstitial lung disease, ocular complications. They have a higher rate of lymphoma, and certainly renal complications and spinal stenosis. Sometimes patients will come into our office and then they'll say, I noticed that my fingers turn different colors. Sometimes this is completely benign, but I do think it's important to begin to think about working those patients up for Raynaud's disease or Raynaud's phenomena. So Raynaud's disease describes primary cause, though this is not necessarily associated with any other rheumatologic condition. It's more common in individuals who are younger, who they will have normal capillaroscopy, and they have no other systemic causes that we've identified. Whereas Raynaud's phenomena is associated with any number of rheumatologic conditions, including vasculitis, lupus, RA, Sjogren's syndrome, and scleroderma. I think what's important to think about here when you're evaluating these patients is, does this represent proximal or distal embolic or occlusive disease, either from a cardiac source or down the upper extremity? Acrocyanosis, Chilblains, CRPS can present this way. Paraneoplastic syndromes are uncommon, but also something just to have in the back of your mind. Thoracic outlet syndrome and thromboangiitis obliterans. What do we think about for the workup for this? Again, evaluating for rheumatologic conditions, cardiac conditions, anything that might be resulting in a embolic or thrombotic phenomena, vascular disease. Does this patient have prior trauma? Is this hypothalamic Hammer syndrome? Do they use nicotine? Have they had any medication changes? Beta blockers and chemotherapeutic agents can also cause new onset of this. And then based on that, considering additional studies such as duplex imaging, formal arteriography, and echocardiography. Many of our patients who come to see us with Raynaud's phenomena also have some other type of inflammatory condition, as we just talked about in the setting of that. One of the most common is scleroderma. So the term scleroderma represents a whole constellation of conditions. It is an autoimmune disease that results in skin and connective tissue disorder, tissue fibrosis that can be localized, it can be systemic, and amongst those with systemic disease, it can be limited or diffuse. So localized scleroderma refers to morphea. It's typically, on a thigh or one specific area. It only involves the skin and local involvement of that underlying tissue. More commonly, what we see are patients with limited systemic sclerosis. This is primarily in the fibrosis of the tissues around the hands, the face, the forearm, and diffuse is a much more aggressive and fortunately more rare condition with earlier sequelae. These individuals can also have complications that include the pulmonary system, cardiac disease, renal disease, and GI manifestations. And this is kind of the classic sclerodactyly picture here with hyperextension at the MP joints, flexion of the PIP joints, and they get ulcerations over the dorsal aspect of the PIP joints. A lot of times we'll see these patients for fingertip ulcerations or little spots of calcinosis, as you can see in the upper photograph there. I do think that there's many things that we can do to help these patients. So if you're seeing them in your clinic for the first time, or you suspect that this one of your patients might have this, or some of their symptoms might represent this, I think it's important to involve rheumatology early. I think that some of the things that we can offer them as hand surgeons are fat grafting, which can help with the mobility over the dorsal aspect of the hand. We can alleviate some of the sequelae of sclerodactyly, including PIP joint fusions, and you can resect a small piece of skin around that area, particularly for patients who might have ulcers over the dorsal aspect of their PIP joints. We can do silicone arthroplasties of their MP joints to help with mobility. And then very commonly, we do Botox injections for Raynaud's phenomena associated with this, and sympathectomies with or without ulnar artery bypasses for patients with refractory Raynaud's phenomena. Lupus is another important rheumatologic condition to have in the back of your mind. I think it's interesting that 90% of patients have hand or wrist symptoms early on. So they may present with non-erosive arthritis, and they have ligamentous laxity and hypermobility. They often will have tenosynovitis, but rupture is uncommon just because of the pathophysiology of the condition. It doesn't necessarily cause tendon infiltration. They often will present with Raynaud's phenomenon, and Charcot arthropathy is the most severe, fortunately, is relatively uncommon. So the vast majority of our patients with lupus may present with ligamentous laxity, particularly at the basilar thumb joint, and hypermobility. Again, lots of nuance to diagnosing this, and involving our colleagues in rheumatology is important. These are some of the laboratory values or serologic markers that we will often send off: ANA, complement, SED rate, CRP, Smith and antiphospholipid antibodies. And then in the picture here, you can see the importance of that. Lots of manifestations of lupus beyond the upper extremity that we want to make sure that we don't miss. Psoriatic arthritis is another important rheumatologic condition to be aware of. This is a seronegative spondyloarthropathy. Patients will present with scaly erythematous plaques, but oftentimes they present with pain, particularly in the PIP and the DIP joints first, before the skin manifestations of this condition. You may also see nail deformities and tendinopathies. Arthritis with this condition ranges anywhere from 6 to 48%. But again, most of the time patients present with arthritis before they develop the skin manifestations. In this particular patient here, you can see they can present with autofusion of the IP joints and diffuse swelling. Late sequelae of this can be what we could describe as pencil and cup deformities, particularly at the DIP and PIP joints and arthritis mutilans. Again, I think the diagnosis is clinical. So being on the lookout for these associated skin lesions, nail lesions, dactylitis in the presence of a negative rheumatoid factor. Again, this is a seronegative condition, but we do often send off labs to look for anemia, elevated SED rate and CRP, ruling out gout and other causes. For the most part, the treatment of psoriatic arthritis is non-surgical until it becomes symptomatic to the point where medications, including biologic DMARDs and others, are not alleviating the symptoms sufficiently for patients and limiting their quality of life. And then in which case, most of our surgical treatments are aimed at alleviating joint deformity and pain. So for example, this patient came in with beginnings of autofusion of her middle ring and small fingers, and we went on to perform DIP fusions of these. And then I'll close out this particular section with Ehlers Danlos. So this is the most common inherited connective tissue disorder. It results from mutations in fibrillar collagen synthesis. And I think this can be challenging to diagnose because it's not always on the front and center of our radar in a busy clinic, but looking for skin hypersensibility, joint hypermobility, and tissue fragility. There's 6 subtypes of this. Oftentimes this will present with thumb pain and hypermobility. You can see this picture here. And the main way that we think about trying to identify patients who might warrant genetic testing is through the Baton criteria, which is here in this table. And I think this is important because there are a number of cardiovascular sequelae to this condition. So getting them plugged into rheumatology after genetic testing is important. All right, I'll close out here with just a couple of examples around infections. So again, common things being common. Sometimes patients will come into our clinic or we'll see them in the ER. My finger is red and swollen and painful. A lot of times this is a very simple cellulitis. It could be a felon, a paronychia. But I do think that it's important to think about other things that might be mimicking that: herpetic whitlow, chronic paronychia, and other atypical infections. So in this particular case, this is an example of herpetic whitlow. You can see the bullae overlying the finger. This is the most common viral infection of the hand. This can be very painful. Patients will come in complaining of throbbing pain and vesicles at the fingertip, most common in younger individuals and individuals who may have healthcare exposures or oral exposures. The definitive diagnosis is made by Zinc smears and our viral cultures. I think what is hard for us, our instinct is to go in and debride these. That is, in general, not what we should do unless you see a super infection like you see down here in the picture, where now those lesions have developed into a bacterial super infection. In that setting, we do debride them, but in the early setting above, this is primarily supportive care, the self-limited course, and we will prescribe acyclovir or severe. Atypical infections are important to also have in the back of our mind. They can mimic other causes of tenosynovitis, like we talked about in some of the other slides. So querying patients about travel, unusual bites, unusual exposures, et cetera, is important. Mycobacterial infections are typically diagnosed definitively using biopsies with AFB and broad-range PCR. Ultrasound and MRI can be helpful, especially if you're evaluating a patient who's got severe tendinosynovitis. This is often over the flexors, over the volar aspect of the hand. So trying to understand the extent of the pathology. And most of the time, this is a combination of medical therapy and surgical debridement. And again, I think sometimes all of these conditions can overlap. So having, a strong working list that's in your differential diagnosis is important for inflammatory arthropathies, unusual things like pyoderma gangrenosum, Sweet syndrome. And then one of my attendings always would say this: biopsy everything you culture everything that you biopsy. So I hope I gave you some things to keep in the back of your mind when you're evaluating patients that are in these categories. And I'll just close again with this. Have a low threshold for biopsying things, have a low threshold for culturing things, biopsy everything you culture everything you biopsy, have a low threshold for additional imaging, and have a low threshold to consult our colleagues, particularly when things seem a little bit out of the norm. Thank you.
Thanks, Jen. That was absolutely wonderful. All three. Congrats, all speakers. That was great. So I'll encourage all the audience members to throw questions into the chat. Sonu and I can field those. We've got a little bit of time. We're supposed to end at 9, but we can run a touch over. And if people need to drop off at 9, that's fine as well. But if there's questions, I want to make sure we try to get to as many as we can. There's one question in the chat already for Marc. They mentioned that they have seen ECU weakness with resistant ulnar deviations, a clinical finding associated with radial tunnel syndrome. And Elizabeth Hager's described that. And your thoughts, is that something you've seen? Do you think it's more just in the really late cases, or is that something you've come across?
Yeah, great question. And she is incredibly smart, and I'm aware of that paper, but not something that I have seen. So I've not personally seen it, but something that's on the radar to be looking for. And you're exactly right. It might just be a prolonged late case that you see it, but it's not something that I've specifically seen.
Yeah, that's been my experience as well. I've read that before, and I've wondered about it. And I've wondered if I've just missed it or something because I didn't do a good exam. But I haven't seen it. But someone in the chat hasn't, and Elizabeth's definitely described it. And I agree with Marc, brilliant person, so worth being aware of it when you're examining for radial tunnel. I don't know if it's a late finding or just one that we don't do as thorough of an exam as we should, and it's actually there a little more than we think. But I would agree. Jen, one of the things I think you hit at the very end that I thought was a really good point too is, especially with some of these bizarre, masses that we see as hand surgeons, they come to us and we're reticent to sometimes make referrals, but maybe talk to everybody about your thoughts on like, when should you be referring to, or at least getting an opinion from our tumor colleagues? Cause I kind of tell my PA, like, look, if there's tumors that are in like weird spots, if they're particularly large, and especially if they're painful, any painful tumor that's not an obvious peripheral nerve sheath tumor that usually are painful, other than peripheral nerve sheath tumors, not many of the ones we see that are benign are painful. So when do you think it's like, hey, I should call the tumor person, at least get their thoughts on this case?
Yeah, I think, when we get referrals for, and a lot of it, the direction is coming from dermatology towards us. I would say, for the more straightforward squamous cell carcinomas, basal cell carcinomas that don't have aggressive features on that initial biopsy, I think that's something that, I feel pretty comfortable with, understanding what the margins are, how we're going to close it. And I think the key there is making sure that they've got good follow-up with a dermatologist and they know what to look for in terms of changing skin lesions. I think it's really important for any type of lesion that we think might need a workup for distant metastases like melanoma, Merkel cell carcinoma, is important to engage our colleagues early because a lot of times they may want to do that workup before the initial tumor excision has occurred. And certainly for lymph node sampling, that's something that I would involve my colleagues in surgical oncology for, to understand, do they need a sentinel lymph node biopsy? Are we thinking about an axillary lymph node dissection? Would this be something that might require preoperative radiation? So again, I think those are more the tumors like the Merkel cells and melanomas.
So do you have any questions for folks as the chats keep coming in for a second?
Yeah, I think we got one more question here regarding, it looks like Taylor wrote that he noticed 2 referrals from dermatology regarding onychopapilloma new to hand, and hasn't had much experience with them either. Any advice? Jen, have you gotten those referrals for that, or are you familiar with that at all, or?
Don't think I've gotten referrals for those, so I don't know if I can comment on that one.
Yeah. So same here. I was thinking in my own mind that I don't think I've seen that either. I think that's something that is quite unique. So I don't think I can. Anybody else in the audience, Marc, or Carrie, or Glenn, yourselves?
2 onychopapillomas? No, I don't think I've ever seen one. I don't know that until you put the word out there that I would have even known it's actually a real thing. So that is I would have, that'd be one of those, when you get it, you read on it for me and then figure out what to do. Marc, you got a bunch of onychopapillomas in your practice?
I'm glad you said that, because I was feel very orthopedic right now sounding out the words, because I don't think that I've heard those stems together.
And then there's one question, Jen, for you on epithelioid sarcoma. Would you also refer that to surgical oncology in your institution?
100%. I think the times that we might see that, or if it's some, small lesion that, again, this is like the less than 0.01% of a case, but if that's what the biopsy comes back as, then that's really important to get our orthopedic oncology or surgical oncology colleagues involved in.
Yeah, I don't know what y'all's institutions are in Charlotte. I'll say one thing, our ortho-oncology people love it when you reach out to them and just say, hey, what do you think about this case? Is this something you want me to just send to you now? Do you want me to biopsy following the principles of biopsy, longitudinal incisions and excisional, and then send it? And if it comes back something, send it to you. Do you want to do the case together? And just kind of giving them those opportunities. They really like that. One thing in our institution they hate is when surgeons do something and then say, oh, oops, it came back something bad, now you take it. They very much appreciate the you taking it out consult. I don't know if that's the same everywhere else.
Yeah, I would echo that sentiment too.
Well, those were great. I think if there's no other questions, I think it's 9:03. Thanks again to Endo for sponsoring this, and to all 3 of you for outstanding lectures, and AHS for putting this on. And now that everybody's members, we look forward to seeing everybody in Hawaii. So thank you for joining.
Thank you.
Thank you.
Thanks.